Good afternoon, dear friends and colleagues and the organizing committee. Today, I would like to share some the trick that I use in my current practice. And we know that the very common major complication or suboptimal result of the orbital wall fracture repair is undercorrection or overcorrection or restrictive strabismus. And content of today is a concept that I use in the evaluate the patient about the grading of the orbital wall and how to choose the right implant for the right patient, whether it be the standard one or the PSI one, and how to do optimal for the outcome for the globe displacement and restrictive strabismus. It's for understanding the bony support concept is very important. If you are the beginner, you have to know and understand about the orbital stud and the posterior ledge. For the orbital stud, we divide it into three parts. The front part is the anterior part, is a very strong part. The mid part is a most fragile one. And the posterior part is one part of the orbital process of the palatine bone. For the palatine bone, is if we are the oculoplastic, we all will understand about the palatine bone. Use a simulation create the medial wall fracture and the floor fracture. And at the posterior part, we can see the orbital process of the palatine bone. If you use an application study about this is body articular plate of the palatine bone, and you can separate and isolate the bone and learn about the configuration, the shape, and the contour. In your axial view, if we can evaluate in the axial view before the surgery, if the green area is show the support of the orbital process of the palatine bone, only a few millimeters left the strong of the orbital stud and the stain of the posterior ledge, it will be enough for put the implant. For the sick grading that I use in my practice, the first one is from easy to the difficult. The first one is isolated medial wall fracture. The second one is isolated orbital floor fracture with good orbital stud and good posterior ledge. The grade 3 is an isolated orbital 4 with good orbital stud but poor posterior ledge. The grade 4 is a medial and 4 and with the good stud and poor posterior ledge. For the grade 5 is a medial and 4 and with poor orbital stud but good posterior ledge. And the grade 6 is the worst grading. It's no support at all. For at least when we're going to put the standard implant, at least 3 points to support. 1, 2, 3, two in the front and 1 in the back. If we have at least 3 points, we can put the standard implant properly and strongly. For the sick grading, for the type from the grade 1 to grade 5, in my practice, I think we can use the standard implant one. But in the old day, 10 years ago, 20 years ago, we have no rapid prototype. But nowadays, I do encourage you to do some printing, 3D printing for the rapid prototype. That help a lot. And it's use only 1 or 2 days for get the implant. And we can use that one pre-operatively and intraoperatively also, and the cost is not that so expensive. And for the grade 6, is no support at all, so we need to use a more specific implant. For the tip and the trick during the surgery, this is to show the patient, the gentleman that had the motorcycle accident and he had a really bad fracture on the left side. When you get the 3D scan, if you have the software, you can download freely. Example, my favorite one is a Holos one. When you order the CT scan, you need to order the fineness is all about 0.625 or 1 millimeter. If you got like that, you're gonna get the very fine, delicate quality of the 3D scout and 3D for evaluation. On this case, when we do the study, we study at the night before the surgery. We learn and be familiar, remember the shape, the contour of the normal side. And then we study on the affect side. And then we remember when you do the surgery, we remember how the contour, because of the four, the configuration of the four is convex a little bit and slight curve up, and they have the transitional zone between the four and the medial wall. So how to overcome the condition of the market restrictive this much. In this case, you have if the fracture is all fracture, so everything is dropped down, you gonna no restriction at all. But if the fracture is the moderate side, it's all orbital tissue entrapped, and the patient can have the significant vertical limitation of the eye movement. And this lady, she got the heat injury by her friend with the knee during the banana boat, and she got the double vision. And when we evaluate, we start with the axial view, sagittal view, and coronal view. We can see that in the posterior part, they have the 50% at least of the four that have fracture. But fortunately, she has a very good support of the orbital stud, and she good support for the posterior leg, and palatine bone is good. So we decide to get the 3D skull model, and we use on the pre-operatively, you can use a simple paper and cut it and shape it and remember it, and then flip 180 degree and do imitate on the fracture side. So at least we can know how many millimeter for the length, for the depth, for the shape. So when we customize the standard implant intraoperatively, that is less costly comparing to PSI implant. And for the post-op evaluation, if you are the beginner, you may need to know that if you follow up the patient on the first week, first month, the eye may get hyperglobus and limitation is still there. If you confidence that intraoperatively you can reduce successfully, your force reduction test is freely 100%. So be sure that after the surgery, by 1 month, 2 months, 3 months, 6 months, the patient will resolve and come back and no restriction and no double vision at all. So when there is no support, that's the most challenging one, how to overcome the globe displacement. This is a case that have the loss of support, loss of the orbital stud, loss posterior leg, loss palatine bone, but we try to put the implant, the standard implant. But the problem is no support at all. If you decide wrong and you put the standard implant in the low support, the implant gonna be dropped down like a springboard effect. So this is an example case of the lady, 18 years old. She is the drum major, and she used the drum, the stick for the drum major, and the one part hit to her left globe very hard, and she got a really bad fracture. And the previous surgeon tried to put the titanium implant on her left eye, but unfortunately they have the really bad restriction and really bad enophthalmos at the end of the surgery. So we can use software and evaluate how much the orbital volume that increase, and do the rapid prototype. And the engineer recommend he can use a software to delete the titanium implant, so we can get the true of the bone, and so evaluate. In this case, I use a technique differently from the current PSI implant. The engineer discussed with me, "Hey, doctor, why don't you try to use the PMMA implant? Because we use the PMMA for the cranial bone defect, we use for the cataract surgery. So in this case, we get the 3D model, and I use the Scotch tape to put in the floor because of the soft tissue is no soft tissue at all. So and then I put the hard air drying tray on that one and let it dry, and then we send the template to the company, and the company use a digital scanner, and then we get the implant on the next day. So when we go to the surgery, the force reduction test is very important. You start on the normal side first, and remember, and you do it on the fracture side, and remember in your brain and hand memory how many % of the resection it is. So when you remove the implant and try to reduce every bone, every restrictive tissue, and when we put the implant, suppose when we reduce remove the implant and reduce before we put the implant, it may be fully and freely for duction test. But when we put the implant in, sometimes it's too tight, sometimes it's too small. So we can do another customize by drill or by shape it for the PMMA implant. This is the benefit of the PMA implant. On this case, on the fifth attempt that I try to do the force suction chair, I can get 100% freely from the force suction chair. That's going to be at the end of the surgery. So we can get a very good result for goal position to come back to nearly 100%. By conclusion, if we know choose the right implant for the right patient and the grading, if we understand the grading of the orbital wall, we can know and the point when we're going to choose the right implant and appropriate surgical technique that can provide the optical outcome for growth discipline and resective strabismus. Thank you.